You know that moment, you're sitting there, the blood pressure cuff tightens, then it starts to deflate, and you're kind of holding your breath, just waiting for those two numbers.
Yeah, the systolic and diastolic.
Exactly, and they feel like this huge verdict on your heart health, don't they? Sometimes you even get that hypertensive label, and maybe that idiopathic tag, too.
Which, let's be honest, just means we're not really sure why.
Right. It's a bit mysterious. But what if those two numbers, the ones from your arm, are actually, well, hiding a much deeper story?
A more complex picture of what's happening inside your cardiovascular system.
Exactly. A story that might actually give you more control than you think.
Mm.
Welcome to the Deep Dive. This is where we grab a whole stack of sources and really try to figure out what's going on underneath.
Get under the hood, so to speak.
Precisely. Today, we're diving into your cardiovascular system, looking beyond just systolic and diastolic to understand the internal hydraulics, our mission, to give you a really clear view of hypertension's roots.
Something that helps you have a much better, more informed chat with your doctor.
Definitely. And to help us navigate all this, we're digging into insights from Dr. Lutz Kraushar.
Right. He's Doctor of Public Health, holds an MSc in Exercise and Nutrition.
Yeah.
Really knows his stuff. You might know his Substack newsletter, Double Check Doc.
Yeah, and he's got over 20 years deep in cardiovascular research, clinical work, medical devices, the whole spectrum.
So he's perfectly placed to show us how those simple cuff readings can sometimes be, well, deceptive.
Deceptive, or maybe even give a false sense of security, right?
It can go both ways. And just to be clear, this isn't about pushing meds or ditching them.
No, not at all. It's about you getting a really solid understanding. Okay, let's get into it.
So those numbers you get, systolic, diastolic, they're just the peak and the valley, the high and low points of this dynamic pressure wave moving through your arteries.
Okay, a wave.
Think of it less like a static number and more like a signal, maybe a whistleblower even. It's telling you about the state of your internal plumbing.
A whistleblower. I like that. So it's hinting at potential issues, but where does this wave matter most? Because I've heard the pressure in your arms isn't necessarily the same everywhere else.
That's a really key point. It's absolutely not the same. The pressure measured way out at your arm is different from the pressure right near your heart or hitting vital organs like your brain and kidneys.
How different are we talking?
Well, there's this thing called pulse pressure amplification. As that wave travels out from the heart, it can actually get bigger. It gets amplified.
Amplified, like turning up the volume.
Sort of, yeah. As it bounces off arterial branches and stiffer sections of the vessels, the peak pressure can climb. So the reading at your arm might be significantly higher than the pressure your heart is actually generating or experiencing.
Wow. Okay, so
Right.
two people could walk in, get the exact same 130 reading on their arm.
And have totally different pressures happening centrally, near their heart and organs, yes.
That seems huge. Why does that difference matter so much?
Because it's the central pressure, the pressure hitting those vital organs, that seems to be more related to long-term damage. High central pressures can silently strain your heart, your kidneys, your brain, even if your arm reading looks okay, looks safe.
So that 130 reading might feel reassuring, but for one person, the internal reality could be much more stressful for their organs.
Precisely. It depends on the physical characteristics of your specific arteries, how stiff or flexible they are. That shapes the wave.
Okay, this is already way beyond just two numbers. So if the arm number isn't the whole story, what is the body actually trying to achieve? Is it really focused on pressure?
That's the fascinating part. No, not directly. The body's primary goal isn't regulating blood pressure itself. It's regulating blood flow.
Flow, like keeping the supply moving.
Exactly. Your organs need a consistent supply of blood perfusion, we call it, to get oxygen and nutrients and clear out waste. There's a great quote from Professor Jarisch back in 1928. Most organs do not need blood pressure, but blood flow.
Okay, so pressure is more like the consequence.
Right. It's the result of the body working to maintain that crucial flow. Think about it. We don't really have pressure sensors sprinkled throughout our arteries.
Right, you mentioned baroreceptors, stretch sensors.
Yes, stretch sensors in your neck, near your heart. They feel how much the artery wall is stretching, which is related to flow and pressure, and they signal the brain to make adjustments.
And those adjustments, they follow certain rules, like physics.
Pretty much.
Yeah.
Your circulatory system is like a closed hydraulic circuit, heart's the pump. And there's a version of Ohm's law for fluids that applies here. Pressure equals flow times resistance.
Okay, break that down. Flow is?
Cardiac output. How much blood your heart pumps out each minute.
Got it. And resistance.
That mainly comes from your smallest arteries, the arterioles.
Yeah.
way out in the periphery. They can clamp down, tighten up, increasing resistance, or they can relax and open up, decreasing it.
So if the body needs more flow to, say, your muscles when you exercise,
Either those arterioles need to relax to lower resistance, or the heart has to pump harder or faster, which will likely push the pressure up, or a combination.
makes sense. But you mentioned something else is crucial here, the stretchiness.
Ah, yes. Compliance. Arterial compliance. Hugely important, often overlooked. Think about blowing up a party balloon.
Okay.
It expands easily, right? High compliance. The pressure inside only goes up modestly. Now try pushing that same puff of air into a stiff garden hose.
Whoosh, pressure spikes way up. Low compliance.
Exactly. Your arteries, especially the big one leaving the heart, the aorta, are naturally compliant. They stretch with each heartbeat, cushioning that pressure surge.
Cushioning it. But doesn't it do more than that? You said something about a second pump?
Yes, this is the brilliant part. After the aorta stretches, it naturally recoils, like an elastic band snapping back. That recoil actually pushes the blood further along during the heart's relaxation phase.
So it helps maintain flow even between heartbeats.
Precisely. It keeps pressure lower near the heart, and it helps propel blood out to the body. It's an amazing design.
But if the vessels get stiffer, lose that compliance.
Then the pressure spikes higher with each beat, that recoil effect diminishes, and the heart has to work harder against that increased pressure.
And compliance isn't fixed, it changes.
It decreases naturally with age, unfortunately, but lifestyle factors play a huge role in how quickly or significantly that happens. Smoking, diet, exercise, they all impact vessel stiffness.
Okay, stiffness connects to something else you mentioned, pulse wave velocity, PWV.
Right, so distinguish between two things,
Okay.
the pressure wave and the blood flow. The wave, that pulse of energy, travels really fast along the artery walls, often over 5 meters per second.
Super fast, like flicking that garden hose and feeling the thump instantly at the other end.
Perfect analogy, that's the wave.
Right.
But the actual blood, the water in the hose, moves much slower, maybe 30 centimeters per second.
Okay, got the difference. Wave versus flow. How does PWV fit in?
Well, as that fast pressure wave travels, it hits branches and points where arteries narrow or stiffen, and some of that wave energy reflects back towards the heart.
Bounces back.
Exactly. Now, if your arteries are stiff, the initial wave, and therefore the reflection, travels faster. Higher PWV.
Faster reflection.
Means that reflected wave gets back to the heart sooner, potentially arriving while the heart is still pumping, adding to the pressure the heart faces. We call that pressure augmentation.
Ah. So a faster PWV suggests stiffer arteries and potentially more pressure stress on the heart because of those early reflections.
You've got it. That's why PWV is such a good marker of the functional health of your arteries. It tells you about their stiffness.
So all these things, flow, resistance, compliance, PWV, they shape that pressure wave we measure. It's like reading the system's fault codes.
It absolutely is. And analyzing that wave shape in detail, pulse wave analysis, could give doctors a much clearer picture of the underlying hydraulics.
But it's not commonly done in a regular checkup.
Unfortunately, no. Not widely available in standard clinical practice yet, which is partly why that idiopathic label persists. We often can see the hydraulic reason if we look deeper.
Okay, so if we can't easily get that detailed analysis, how can we start to understand what might be going wrong? You mentioned control systems.
Yes, understanding the body's 3 main control systems is key. These are the levers the body pulls to manage flow, resistance, and compliance.
Liver number 1.
The autonomic nervous system, or ANS, think of it as the fast responder, those baroreceptors, the stretch sensors. They talk directly to the ANS.
In the brainstem, correct?
Correct. And the ANS makes super fast adjustments second to second, tweaking your heart rate and how constricted your blood vessels are. It's constantly working to keep blood flow and pressure around a certain set point.
Like the body's immediate reaction force. Okay, what's the next level of control? More strategic.
That would be the renin-angiotensin-aldosterone system, or RAAS is the master strategist. Slower. Uses hormones.
Hormones, okay.
Yeah.
How does it work?
When your kidneys sense they aren't getting enough blood flow, they release an enzyme called renin. This kicks off a chain reaction that ultimately produces a powerful hormone called angiotensin II, or ANG2.
And what does ANG2 do?
It's a potent vasoconstrictor. It tells blood vessels all over the body to tighten up. That increases resistance, which, as we know from Ohm's law, increases pressure. It also triggers other effects like retaining salt and water, further boosting pressure. It's a complex feedback loop.
Okay, ANS for fast reactions, RAAS for slower, bigger strategy. Is there a third?
Yes, the local manager, the endothelium.
The lining of the blood vessels themselves.
Exactly. It's incredibly important. A healthy endothelium, that thin inner lining, produces nitric oxide, or NO.
Ah, nitric oxide. I've heard of that. It relaxes blood vessels.
It's a powerful vasodilator, yes.
Yeah.
Helps keep arteries flexible and open. But if the endothelium gets damaged or dysfunctional, maybe from inflammation, high blood sugar, smoking,
Then what happens?
it produces less NO, so arteries become stiffer. Even worse, a dysfunctional endothelium can start releasing substances that actually cause constriction, like endothelin-1.
So it flips from being helpful to harmful.
It can, yes.
Yeah.
And this chronic stiffness, this endothelial dysfunction, is really problematic because it can actually trick the baroreceptors. It can slowly reset their set point to accept a higher pressure as normal.
Oh, wow. So the body starts defending a higher pressure.
That's how it seems to happen. It's like the whole system starts circling the drain towards chronically high blood pressure or hypertension. The dysfunction feeds itself.
Understanding these three systems, ANS, RAAS, endothelium, really clarifies things. And I guess this is where medications come in. They target these systems.
Precisely. Different classes of blood pressure drugs work on different parts of this control network. Beta blockers, for instance, calm down the sympathetic part of the ANS.
Okay.
ACE inhibitors and ARBs target the RAS system, reducing that angiotensin II vasoconstriction. Calcium channel blockers work more directly on the smooth muscle and the vessel walls, helping them relax.
And you mentioned ARBs are often well tolerated.
Generally speaking, yes, they tend to have fewer side effects for many people compared to some older classes like ACE inhibitors, which can cause that cough.
Right, so the drugs are hitting the mechanisms that maintain high pressure, but
Yeah.
it still leaves that question, doesn't it? What made those systems go haywire in the first place?
Exactly. The drugs manage the symptom, the high number, but they don't necessarily fix the underlying reason why the ANS, RAAS, or endothelium became dysfunctional.
And that leads us right into some big debates happening in medicine right now about how we even define high blood pressure and how aggressively we should treat it.
Oh, absolutely. Huge debates. One of the most obvious is the threshold dispute.
The US versus Europe thing.
Exactly. In the U.S., the American Heart Association guidelines say hypertension starts at 1,380 millimol/mg.
Okay.
But in Europe, the European Society of Cardiology sticks to the older threshold of 1,490 millimol/mg.
That's a massive difference. That 10-point shift in the US, didn't that suddenly classify millions more people as having high blood pressure?
It did. The estimate was, overnight, the proverbial stroke of a pen turned 54 million adults into patients. It's a fundamental disagreement on where to draw the line.
What's the thinking behind the difference?
Well, the U.S. view, based heavily on trials like SPRINT, takes a population health approach aiming to prevent more events across the whole population by treating earlier and more aggressively. The European view expresses more concern about potentially overdiagnosing and overtreating individuals, especially those at lower absolute risk. Same data, different interpretation of risk versus benefit.
Speaking of SPRINT, that trial gets cited a lot, but there's some controversy there too, right, about the evidence exaggeration.
Yes. SPRINT showed about a 25% relative risk reduction for major events in the intensively treated group. That sounds impressive.
Yeah, 25% sounds huge.
But when you look at the absolute risk reduction, it was only 1.6%.
Whoa, okay. 1.6%. What does that mean in practical terms?
It means you'd need to treat 63 high-risk people intensively for about 3 years to prevent just one event like a heart attack, stroke, heart failure, or cardiovascular death. That's the number needed to treat, or NNT.
63 people treated for 3 years to help one person avoid one event. That puts the 25% number in a very different light.
It does. And importantly, follow-up data from SPRINT suggests that even that small benefit seemed to disappear over the longer term, around 10 years out. The groups look pretty similar again.
And didn't SPRINT have some limitations? Weren't certain events not actually reduced significantly?
Correct. If you look closely, the main benefits were in reducing heart failure and cardiovascular death. Actual heart attacks and strokes weren't significantly reduced by the intensive lowering in that trial.
And there was another big trial, ACCORD, with diabetic patients.
Right. ACCORD was kind of the blueprint for SPRINT, but in people with diabetes. It found no evidence that the strategy of intensive blood pressure control reduces the rate of a composite of major cardiovascular events. No significant benefit there either.
So if you pull back even further, meta-analyses combining lots of trials.
The biggest one, looking at 68 trials, found that for every 10 millimole Hg drop in blood pressure, the absolute risk reduction for major events was generally 2% or less.
So if aggressive lowering isn't preventing the vast majority of events, even if it lowers the number, it makes you question if blood pressure is always the primary driver, or maybe just a marker for something else.
That's a really important question being asked.
Yeah.
Perhaps in some populations, like comparing the US and Europe, factors like obesity rates might be playing a bigger role in overall cardiovascular mortality than just the blood pressure differences.
Yeah.
Maybe we're sometimes, as Dr. Kraushaar puts it, barking up the wrong tree by focusing solely on the pressure number.
Okay, another big challenge, just getting an accurate number in the first place, the measurement maze.
Oh, definitely. Blood pressure fluctuates wildly throughout the day. A single reading in a doctor's office could be really misleading. White coat hypertension is real.
Yeah, the stress of being there spikes it.
Exactly. That's why both U.S. and European guidelines now heavily push for home blood pressure measurement, HBPM. The ESC in Europe actually makes it mandatory for diagnosis if the office reading is above 1,989.
Using your own monitor at home, taking multiple readings when you're relaxed.
Yes, it gives a much more realistic picture. Ignoring this variability, relying only on office readings, can lead to big errors.
How big?
Potentially, up to 1 in 3 people with normal pressure get misdiagnosed as hypertensive. 1 in 5 actual hypertensives might get missed. And maybe 4 in 10 people whose pressure is well controlled on meds might get those meds increased unnecessarily based on high office reading.
That's staggering. So getting accurate home readings is absolutely critical for you, the listener, to manage this properly.
Couldn't agree more. Which brings us to, okay, what do we do? What's the real solution?
Right. If drugs manage symptoms and measurements are tricky,
the foundation has to be lifestyle. There's a great line. A pill can lower the pressure, but only a lifestyle change can fix the pipes.
Fix the pipes, address the underlying stiffness, the endothelial dysfunction, maybe calm the ANS and RAAS naturally?
Exactly. Lifestyle changes can actually help reset those malfunctioning control systems we talked about. Drugs should really be seen as an add-on to lifestyle efforts, not the first and only step.
Is there evidence that lifestyle really makes that much difference, even for tough cases?
Absolutely. Look at the TRIUMPH trial. These were people with drug-resistant hypertension meds who weren't working well. Through intensive lifestyle changes alone.
What kind of changes? Diet, exercise?
Comprehensive changes, yes. They saw an average drop of 12.5 millimole Hg in systolic pressure.
12.5 points, that's huge. That's similar to the difference between the treatment groups in SPRINT, but done with lifestyle.
Precisely. It shows the power of addressing the root causes.
But, let's be real, sticking to major lifestyle changes is hard.
It's incredibly hard. Adherence is often, frankly, abysmally poor. And doctors usually don't have the time needed for intensive lifestyle coaching.
So often you're kind of left on your own to figure it out?
That's frequently the reality, yes.
Yeah.
Which makes understanding your options even more important.
Okay, so if medication is needed as part of the plan, how do you choose? You said most first-line drugs are broadly equal for preventing big events.
In terms of major outcomes, yes, the main classes are generally similar. So often the best choice comes down to tolerability for the individual. What can you take consistently without bothersome side effects?
And ARBs often win on tolerability.
They tend to, yes. There's that note about ethnicity, especially for Black individuals, where guidelines sometimes suggest diuretics or calcium channel blockers first. But the evidence for individual tailoring versus broad ethnic categories is still debated. Personalization is key.
Personalization. That brings up something fascinating you touched on earlier, the idea of the non-responder.
Ah, yes. People try a diet or exercise and say, it didn't work for me, I'm a non-responder.
Yeah.
Dr. Kraushaar's insight here is powerful. There is no such thing as a non-responder.
No.
It's not that you don't respond, it's that you haven't found the right intervention for you.
Your specific physiology needs a specific approach.
Exactly. Which leads to the idea of N of 1 self-experimentation.
N of 1, meaning an experiment with a sample size of 1 yourself?
Precisely. It's actually an FDA-recognized approach for individuals to systematically figure out what works for them. Finding your personal minimum viable health habits, or MVHH.
Minimum viable. Like the smallest changes that give you the biggest effective result.
You got it. So maybe for you, a specific type of exercise really improves your endothelial function and lowers resistance. Maybe for someone else, reducing salt intake makes a huge difference. While for you, it doesn't do much. Maybe it's stress management or improving sleep.
It's about becoming a detective for your own body.
Yes. Using tools like home blood pressure monitoring to see the effects of different changes you try. Dr. Krashar does this himself.
Right, you mentioned his vascular age.
Yeah, he uses technology that measures his pulse wave velocity and translates it into a vascular age. And by consistently applying his own MVHH, a dedicated exercise routine, but with flexibility, he keeps his vascular age significantly younger than his actual age, like mid-50s vascular age when he's nearing 70.
That's incredible and incredibly motivating. It shows this isn't just abstract theory, it's something you can actively manage and track.
It really is.
Yeah.
He uses his own body's signals, those fault codes, to guide his habits and achieve remarkable health.
So, wrapping this up, we've gone way beyond just two numbers today. We've dived into the hydraulics, the control systems, the debates around treatment.
Hopefully giving you a much deeper understanding of cardiovascular health than perhaps even your average GP might have time to discuss.
It really underscores the power of personalization, doesn't it? Guidelines and meds have their place, absolutely. But maybe the real key to mastering your blood pressure lies in becoming that detective for your own body.
Using tools like HBPM, understanding these concepts, maybe even trying some careful N-1 experiments to find your minimum viable health habits.
So the final thought for you, the listener, is this. How will you start to decode what your unique cardiovascular system is trying to tell you?